Hi everybody, welcome to Dr. Manny's YouTube Learn Shops. This is about chest X-ray interpretation and it will be a 5-part series starting with this one, the fundamentals. This is just the basics. This is Willem Conrad Röntgen, who gave his name to the chest X-ray or the X-ray or the Röntgogram. And he's considered the father of the X-rays because he was the creator, he was the inventor. The objectives for this Learn Shop are to review how images are created on X-ray films, review the anterior-posterior X-ray view, look at the lateral film, discuss the 4 densities, look at various technical issues related to taking an X-ray, always employ a systematic approach to interpretation, identify intrathoracic structures, and review common terminology that's employed during X-ray interpretation. What then is a chest X-ray? In simple terms. Well, in simple terms, it's an X-ray beam that penetrates matter. It creates a black and white photo. It's a photo of the intrathoracic structures. And as a consequence of this photo, it creates a 2-dimensional image, which is a common photo. But just like all photos, if you're taking a picture of your mother, you realize that that's your mother. If you're taking a picture of a dog, you realize that's a dog. So if you're taking a picture of the thorax, you've got to have an idea of what's in the thorax. And this is where we have our vital organs such as the heart, the lungs, plus or minus the liver or bowel, which encroaches on a chest X-ray, large vessels such as the aorta, superior and inferior vena cava. They're all components of a chest X-ray. What's an X-ray film cassette? Well, the X-ray film cassette is what's placed under or in front of the person being X-rayed. And it's just like photographic film. It has to be exposed and it has to be developed in order to get your picture. There are 4 X-ray densities when you review an X-ray. And you can think of the densities as colours. And the densities are related to air, fat, fluid or tissue, and bone. The least dense is air. And as a consequence of it being not very dense or not very thick, it's referred to as being radiolucent. And it creates a black image on the film. Fat or subcutaneous tissue is a little bit more dense. So it will impede the beam going through to the film to a certain degree. And as a consequence of that, it won't be black, it will be grey. Fluid and tissue is off-white. It's a little bit thicker. It's a little bit more dense. So therefore it impedes or inhibits the beam getting through to the X-ray film, which makes the image off-white or a sort of a creamy colour. Bone is the most dense. It's referred to as being radio-opaque or really, really white because it now inhibits most of the X-ray beam getting to the film, and because that happens, it creates a white image on an X-ray. Air is the least dense, it will be black. Bone is the most dense, it will create an image that is white. In between, you have fat or subcutaneous tissue, which will create a grey image, and fluids or tissues will be off-white. Not quite white, but off-white. What actually creates the image, the intrathoracic image on a chest x-ray? Well, we said there are 4 densities: air, fat, fluid and tissue, and bone. Air is the least dense, so it doesn't block any of the x-ray beam getting to the film. That's why it's black. So intrathoracic structures that are filled with air, such as the lung, will appear black. Fat, on the other hand, blocks a little bit of the x-ray beam getting to the film, and it will appear grey, such as the tissues related to fatty areas, such as the arms, or the armpits, or the skin. Fluid-filled organs or tissues such as the heart, the aorta, the liver, the spleen, they will block more of the x-ray beam, which means less beam is getting through to the film. And as a consequence of that, you'll see the heart as being off-white, or the aortic arch being off-white, or the liver being off-white, or any of the fluid-filled structures such as blood vessels being off-white, the vascular markings. Bone, we said, was the most dense. It's radio-opaque. Opaque just means not clear. It's white. If something is opaque, it's white. It's because the bone blocks most of the x-ray beam from getting to the film. And as a consequence of that, bone will typically be white. Now you've got to think of what I just told you in a different way. The x-ray beam actually isn't being blocked by the intrathoracic structures. The intrathoracic structures such as the bones, the ribs, the thorax, the heart, the liver, the bowel, the spine, they're actually absorbing the x-ray beam. That's why it's not a good idea to be exposed to too many x-rays, because x-ray beams are radioactive. They're radioactive wavelengths, and the beam that's being used for the chest x-ray is actually being absorbed by the intrathoracic structures. And as a consequence of that, if you've got a dense organ like bone, it's absorbing the x-ray beam. And as a consequence of that, it won't get through to the film. More importantly, too many x-rays may cause blood dyscrasias like leukemia. It may affect cells which are in the tissues. So what creates the x-ray images is that the beam is actually being absorbed by the intrathoracic structures, and the more that it absorbs, the more the image is seen on the chest x-ray. The 4 densities are air, radiolucent, least dense. Bone is radio-opaque, most dense. Fat and fluid and tissues are in between, and they will create an image that is either grey, greyish, or off-whitish. When scanning an x-ray, a chest x-ray, think of 5 components. When you're looking at the x-ray, you've got an idea of what it should look like, even though you're not an expert. And think of it in the context of, gee, I'm looking at the x-ray, look at this x-ray now, this is too white. Then you look at the x-ray and you think, oh my goodness, this is too black. Then you look at the x-ray, and even though you're not an expert, you know that a normal heart shouldn't be too big, but this intrathoracic structure looks too big. It's too big. Then you can think of, gee, the lungs should be sort of the same, or whatever the intrathoracic structure is, it should be like this. This one, however, on the right side, looks a little bit too small. The right lung looks a little bit too small. You don't know why, but you think it's too small. Then you think of, gee, this intrathoracic structure, whatever it is in the wrong place. This is an example of dextrocardia with situs inversus. And basically the heart is in the wrong place. You don't know why it's there or what it is, but you know that the heart normally sits on the left side. This one is sitting on the right side. So it must be in the wrong place. When interpreting a chest X-ray, always use a systematic approach. And you're supposed to use a systematic approach for all types of procedures. So the systematic approach that I'm recommending here is, first of all, identify that you've got the correct patient. Patient identification is a common medical error in healthcare. Look at the date and look at the time to establish when the chest X-ray was taken, and look at the technical quality, which we're going to be reviewing shortly. Then scan the film from the outside to the inside so that you don't miss anything. So you're looking at from the point of view that you're looking at the thorax or the chest wall, which is primarily to do with the ribs, or the bony structure, the clavicles, the spine, the ribs. Then look at the pleura. Then migrate to the lungs. Make sure everything is symmetrical. Symmetrical basically means the right side looks like the left side. It won't be absolutely the same because the right lung is different to the left lung. And the heart silhouette is different from the right side to the left side. But basically, they're symmetrical. They sort of look the same. Look at the mediastinum. The mediastinum just doesn't consist of the heart silhouette. It consists of the aorta, superior vena cava, inferior vena cava, and it's got the spine in it as well as the trachea. So look at the silhouette. And then look at the diaphragms. Look under the right hemidiaphragm, left hemidiaphragm, which incorporates the costo and cardiophrenic angles, in addition to the liver on the right side and the stomach on the left side. So therefore, even though we're not looking at the abdominal organs, there are abdominal organs or abdominal abnormalities or anomalies that could be observed in a chest X-ray. Always use a systematic approach. What are you observing for? Remember the 5 points that we just mentioned before. If you see something that's too white, it could be abnormal. If you see something that's too black, it could be abnormal. If you see something that's too big, it could be abnormal. If you see something too small, it could be abnormal. If you see something that's in the wrong place, it could be abnormal. It may not be, this may be an adult who is born with dextrocardia. And as we said, situs inversus, which basically means the stomach is on the right side under the right hemidiaphragm, and the liver is on the wrong side under the left hemidiaphragm. However, if we know that because of the patient's history and physical assessment, then we're not too worried about it. Always then evaluate X-rays with the patient's history. This could be their medical history, their surgical history, their medication history, any number of different histories, their family history. Always evaluate the X-rays in light of their physical assessment findings. For example, if a patient's got respiratory distress, then maybe they've got a problem in their lungs, which will be seen on the chest X-ray. Think of the patient's clinical findings. Sometimes in certain conditions, let's think for an example, acute respiratory distress syndrome, the X-ray can look quite healthy initially, and the patient can be clinically really sick. Always look at serial X-rays, chest X-rays, because the X-ray may have been taken 10 years ago, and you can compare it to what it is now 10 years later. And as a consequence of that, it may give you information. Then look at the technical quality. How was the X-ray taken? Because if it wasn't taken correctly, for example, you may take a photograph of someone in the dark and the camera didn't work properly and you can't really see the image clearly. The same thing applies here. The technical quality consists of 5 main points: projection, orientation, penetration, rotation, and inspiration. The degree of inspiration, which we're going to be reviewing. Projection is the first aspect related to the technical quality of a chest X-ray. And projection basically is, where is the beam coming from? Where is the direction of the beam? And the beam's direction can consist of a posterior-anterior approach, an anterior-posterior approach, a patient who is supine, erect, in a lateral position, or laying down in a decubitus position. The posterior-anterior chest X-ray is probably the best. It's standard, and it will give the most accurate information. And typically a PA film is where the film cassette is placed in front of the patient's chest and the beam is directed towards the film through the patient's back. The patient distance is important as well, otherwise this can alter the image. And the patient distance from the camera projecting the beam is approximately 72 inches. The advantages of a PA film are that all the intrathoracic structures are typically correctly positioned and well proportioned on the chest X-ray film. Nothing looks too big, too white, too small, too black, or in the wrong place, typically. The anterior-posterior chest X-ray, this is typically where the film is under or on the patient's back. And this is for patients who are typically unable to have a PA film. And this could be, as an example, a really sick patient. Someone who's now traumatized, motor vehicle accident, who's in the emergency department. Or they could be in the ICU or an acute care area. And this is where the beam now is coming from the camera and it's going directly through the patient's chest to the film which the patient is lying on. And typically the patient distance from the camera is about 40 inches, which may make the intrathoracic structures a little bit bigger. So the advantages of an AP film are, look, it's convenient, it's portable. You don't have to put the patient at risk by transferring them to the radiology department when they're in the emergency department or the intensive care or any acute care unit such as a high dependency unit or a pediatric or neonatal ICU. The disadvantage, however, is that not all the intrathoracic structures may be correctly positioned. Despite you trying, they may not be positioned correctly and they may appear enlarged as a consequence. Another component of projection is the erect position. And the erect position is a good position as well because if there's any free air in the pleura, it may rise to the apex and become visible. If there's any free fluid in the pleura, it can move to the bases and become more visible. If you want to identify whether the stomach is in the right place, then gastric air may be visible as well. So the erect position is a good position to take a chest X-ray in. In comparison, supine positioning may not show abnormalities or anomalies or air or fluid as clearly as the erect position. And in the supine position, the patient is laying on their back, and if there are any pleural effusions or collections of fluid in the pleura, they may disperse and not be seen as easily. The same thing applies to free air. If there's a pneumothorax, it may gravitate superiorly and you may not see the pneumothorax as clearly. So in the supine position, pleural air typically gravitates superiorly and maybe hidden in relation to the sternum and the upper, which may not be seen clearly. And by the same token, pleural fluid gravitates inferiorly and may present an image that isn't actually accurate. But supine positioning may be important because the patient is hemodynamically unstable, or they may have injuries that don't allow them to be put into an erect position. Projection can also be using a lateral chest X-ray. And a lateral chest X-ray is basically taken to confirm something that you saw on the AP or PA film and you want to see it more clearly, or you want to identify the location of it. So it's just an adjunct to your PA film or your AP film. It isn't typically taken routinely. Projection can also come with a Decubitus X-ray. And a Decubitus chest X-ray is taken with the patient or the victim lying on their side. And primarily it's to identify fluid that was seen or thought to be seen on an AP or a PA film. And have a look at the X-ray there. You can see the red arrows highlighting whiteness. Whiteness, remember, is fluid or tissue or bone. This one is very, very, very white. It's very radio opaque, and this indicates that the patient now has a fluid level in their right lung or on their right side or on their right pleura. However, remember, if you're taking a Decubitus chest X-ray, the patient probably has to lay on that side for at least 10 or 15 minutes for the fluid to migrate into that dependent position. It just doesn't go there as you would do with a glass of water. It will take some time to migrate there. Orientation refers to where. Is it the right side or the left side? And this is where the radiographer marks the X-ray, right or left side, because there are two lungs, a right lung and a left lung. And it's to orientate the viewer to the image. And this is done to minimize incorrect interpretation, which can potentially result in incorrect interventions. Rotation is another technical problem. And rotation basically means, is the patient in a straight position or are they twisted? And rotation is important to be aware of because it will affect the interpretation of the chest X-ray, because the intrathoracic structures may be altered in their position. So therefore it's important to check for rotation, and this is done by looking at the chest X-ray and making sure that the clavicles are symmetrical, meaning that they're basically in the same position. Look at the chest X-ray with the yellow arrows. So they're the medial ends, middle, towards the center, and they're basically in the correct position. The highlighted one in red is showing you here that the medial ends of the clavicle are equidistant from a spinal vertebrae. And that basically tells you that the patient is in a straight position and they are not twisted, they are not rotated. So the image that you see, whether it's the lungs, aorta, heart, spine, they're in the correct position. No rotation. No rotation, X-ray on your viewing left, not rotated. On your viewing right, you have rotation, which, have a look, could alter the intrathoracic structures, the images that you're trying to see. Rotation distorts the intrathoracic images that you want to see. Penetration is another technical aspect. And penetration basically means how much beam or dose of radioactivity or wavelength has been used by the radiographer. And typically the dose is 60 to 125 kilovolts at a speed of 0.2 or greater milliamp seconds. Is this important? Well, it sort of is really if you're looking at the chest x-ray, because you want to have an idea, because this will be documented on the x-ray film, what the radiographer used. They will be documenting, for example, here that they use 60 kilovolts at a speed of 0.2 milliamp seconds. And if the dose has been correct, the vertebrae and the lung blood vessels are just visible in the heart shadow. So you look at the heart shadow and you can see you've got a sort of blurry image of the spinal vertebrae. And you can see blood vessels or vascular markings through the heart shadow. This is a non-exact science, but this will indicate that the beam that was used has been used at the correct dose. If too much has been used, then it's too black. This means that the film has been overdosed or over-penetrated. And how is that known? Because the vertebrae and the lung blood vessels are very, very visible. They're really, really clear in the heart shadow. And this indicates too black. As we said before, too white, too black, too big, too small, in the wrong place. This is too black. And as a consequence of it being too black, it highlights the white images. And this may distort what you're actually wanting to read or interpret on the chest x-ray film. If not enough x-ray beam has been used, too little, it's underpenetrated or underexposed. And because it's underpenetrated, the spinal vertebrae and the lung blood vessels are hidden. They sort of blend into each other. Because remember, the spinal vertebrae are white, the heart shadow is white, the heart blood vessels are white, and as a consequence of that, it's too white. And because it's too white, you can't actually see what you want to see on the chest x-ray film. And therefore, interpretation is now affected because of the way the picture was taken. This is the final component, technical component, which is referred to as the degree of inspiration. Typically, an inspiratory film is correct if there are 5 to 7 anterior ribs, or there are 9 to 10 posterior ribs that can be seen on the x-ray film from the level of the mid-hemidiaphragm, right or left, it's your choice. On the film that you see in front of you, the inspiratory film is on the right side. It's going to the hemi-half diaphragm and it's going up and counting the ribs. If you count the ribs, you can't typically see or read anterior ribs on an AP film. This is an AP film. And an AP film typically shows you the posterior ribs. And there are 9 to 10 posterior ribs. If you count them, there are actually 9 posterior ribs. So this film has been taken during inspiration. And if you take the film during inspiration, all the intrathoracic structures should be clear and in the correct position and at the correct size. Let's make a comparison on the same chest x-ray taken during inspiration compared to expiration. And as you can see, the images are not the same. They're not the same. So this can alter an image and maybe highlight things like, if we make a comparison, the heart shadow on your viewing left is correct during inspiration. On your viewing right during expiration, it appears a little bit larger, which could alter your interpretation and say maybe there's an element of cardiomegaly here. When we look at the chest x-ray and compare them to different patient populations, well look, I mean, neonates are different to adults. However, from my perspective, adult, child, infant, neonate, the general principles of chest X-ray interpretation for all populations are similar. They're not exact, they're similar. But we also have to remember that it's the radiologist that does the interpretation and tell you what is actually on the X-ray, because they're the experts. So when you're looking at chest X-rays, remember who you are. Whether you're a physician, whether you're a nurse, whether you're a radiologist, it's the radiologists who are the experts, and they make the final interpretation. When we want to identify intrathoracic structures on an anterior-posterior film, we can see bony structures, the trachea, bronchi, bronchioles, the lungs. We can see the lung blood vessels or markings. We may see fissures and lobes. We will see the diaphragm and any abdominal structures that may be under those diaphragms. The bony structures are essentially the vertebrae, the ribs and the sternum. And this can be seen on both an AP film or a lateral film. And it's the bony thorax that's formed by the sternum, as we said, 12 pairs of ribs and 12 thoracic vertebrae, and their function is primarily to protect the vital organs, which are the heart, the lungs, and major vessels like the aorta, superior vena cava, and inferior vena cava. Then you've got the trachea, or the bronchi, and these are the large airways that are visible on a chest X-ray. The trachea typically branches at the carina into the left and right main bronchi, which can be followed as they branch beyond the hilar into the lungs. The hilar are the areas of blood vessels that are related to the right and left pulmonary artery, which on this image is typically located around the right main bronchus and the left main bronchus. The carina is just the bifurcation. You have the right main bronchus and the left main bronchus. They're the bifurcations. Then you have the vascular markings, and the vascular markings are the blood vessels, the pulmonary blood vessels. And these can come from the hilar, which is the main area located at the heart, and they migrate out to the peripheries, all the way out. And the vascular markings are essentially whitish, because remember, blood vessels are full of fluid. The fluid is blood, can be thought of as tissue as well, and as a consequence of that, the X-ray beam will be absorbed by the blood vessels. So the pulmonary blood vessels, they normally extend from the heart, which is the hilar, which basically means where things go in and out, such as the blood vessels, the nerves, they could be arteries, veins, they could be lymphatics. So the hilar to the outer peripheries. You should see the blood vessels going all the way out to the bony structure. Then we have the pulmonary fissures. And a fissure is just a crack, really. Well, it's not a crack in the lung, but that's what it is. And it's a separation. And the left lung is divided into two lobes, the upper and the lower lobe, and it's divided by the diagonal or the oblique, or referred to as the major, the biggest fissure. The right lung has got two fissures, the diagonal and oblique, and the horizontal fissure. And it separates the lung into three components, or three lobes, the upper and the middle and the lower. However, only the horizontal fissure is commonly seen on a frontal chest X-ray, and it may not be seen on an AP film. Typically, it may be seen on a PA film. If there are accumulations of fluid, alveolar edema, then you may see fluid collections within these fissures. The pulmonary lobes. The lung essentially consists of 5 lobes. The left lung has got a superior and an inferior lobe. The right lung has got a superior, middle and inferior lobe. And it's the fissures that separate the lung into their different lobes. The diaphragm is the muscle that separates the lungs from the abdominal organs. And there are 2 hemidiaphragms. Each hemidiaphragm, right or left, should appear smooth and dome-shaped in contour. The right hemidiaphragm is usually a little higher because of the liver than the left. The left hemidiaphragm usually has a bubble of air below it. This is air in the stomach, but it may not have. Variants that can occur with a lateral chest X-ray, you still have bony structures, the trachea, bronchi, lungs, fissures, lobes and the diaphragm, but the image is a little bit different. And remember, we said typically a lateral X-ray is not done routinely. It's typically done to highlight or identify structures which could be normal or abnormal that were seen on a PA or an AP film. Still we have bony structures, the vertebrae, the ribs and the sternum. We have the trachea and bronchi, which are the large airways which were visible on the PA film and the AP film, but they're also visible on the lateral chest X-ray. However, they're not as visible in this view compared to the AP or the PA film. Then you've got the right lung, and this consists of the lobes and fissures. The right lobe again is divided by the diagonal, oblique and horizontal lesser fissures, where the horizontal lesser fissure divides the upper and middle lobe, the oblique fissure divides the middle and lower lobes. The left lung consists of 2 lobes, as we said, the left upper lobe and left lower lobe, and both are separated by the diagonal and oblique, the major fissure. The diaphragm on a lateral chest X-ray has a double dome effect. The diaphragm is higher on the right side under normal circumstances than the left because of the liver. And this allows the liver to be sited under the lower edge of the right thorax, while the left is lower, which allows the heart to sit on it. And that's how it's sited. Now let's look at some of the cardiovascular landmarks on a chest X-ray. And typically we have the superior vena cava, inferior vena cava, right atrium, right ventricle, left ventricle, aorta and the pulmonary trunk. And this is now visualized here on the chest X-ray. Superior vena cava located number 1. Inferior vena cava located below number 2. The right atrium combines both vena cavas. This is the right atrium number 3. The right ventricle is seen as number 4. The left ventricle is seen as number 5 because under a normal circumstance or a normal image, the left ventricle is posterior. The aorta, number 6, leaving the heart, left ventricle, and the pulmonary trunk, number 7. Using a chest X-ray, we can also estimate the heart's approximate size by using a ratio called the Cardio-thoracic ratio. And this is determined by measuring the difference between the heart's width and the chest's width. And you can measure it. This can be done in adults, in children, and in infants. The normal adult cardiothoracic ratio is less than 0.5, which basically means the heart silhouette is not allowed to be more than half the size of the thorax in total. So a normal adult has a cardiothoracic ratio of less than or equal to 0.5. And its measurement is typically done at the widest point above the costophrenic angles. If it is greater than 0.5, it may indicate cardiac enlargement, but on an AP film, sometimes the cardiac silhouette, because of the way the film's been taken, may be enlarged. There's an example. There's a normal heart shadow or silhouette, and there's an abnormal, which could indicate congestion, congestive heart failure, cardiomegaly, an enlarged heart. If we look at the pediatric cardiothoracic ratio, and we're really typically looking at infants, it's typically less than 0.65. Infants are a little bit smaller, the heart shadow is a little bit larger. So a normal infant has got a cardiothoracic ratio of typically less than 0.65. Measurement again is done at the widest point above the costophrenic angles, and greater than 0.65 may indicate cardiomegaly. Normal, abnormal. Now let's review some common X-ray terms that are employed when looking at chest X-rays. You have tracheal deviation. On the image that you can see in front of you, the air bronchogram, or the tube there, the trachea, is typically full of air. It's deviated to the right side. Now this can be false because of rotation. It's a technical error. Or it can actually be true because there's a tumour located, for example, near the thyroid. It could be pushed out of position, deviation, due to a goiter. It could be pushed out of position because of atelectasis, pneumothorax, or a mediastinal shift. Tracheal deviation. It's not midline. It's not straight. Then we can have what is called increased density. We said too white. For some reason it's too white. Normally in the lungs you've got symmetry. Symmetry means basically the same. You've got equal transradiancy or blackness on the right side and on the left side. So typically this may be false because of over-penetration or under-penetration. Increased whiteness is under-penetration. This can now be true because there's a tumour or a lesion, increased tissue, an abscess, fluid such as pleural effusion, trauma, blood, hemothorax, atelectasis or collapse. Normal chest X-ray, increased whiteness on the right side there, right upper lobe collapse. Or it could be a fluid collection. Or it could be pneumonia. There's a pleural effusion on the left side, a huge pleural effusion, which is now encompassing the left upper lobe and the left lower lobe. Atelectasis. Atelectasis basically means lung collapse. Now, this could be a technical error related to underpenetration. If it was true, then it would be a tumour, fluid, pleural effusion, plugging, mucus, trauma from blood. I mean, there's an example here where you've got tracheal deviation to the right side as a consequence of atelectasis. And because you get atelectasis, it pulls the trachea over to that side. But this is an example of right lung complete atelectasis collapse. Mediastinal shift. This means that the mediastinum, which encompasses the esophagus, the aorta, superior vena cava, the heart, the inferior vena cava, it's been moved. And this could be as a result of a technical error, they're rotated. But when we look at this chest x-ray, it's not too bad. The clavicles aren't perfectly symmetrical, but the medial ends seem to be okay. When we look at true mediastinal shift, we're looking here. So here, this patient isn't rotated, the clavicles are medially correct. However, this is an example of a tension pneumothorax, which on the left side is pushing the heart towards the right side. So true mediastinal shift may be caused by atelectasis, as we saw in the previous x-ray, tension pneumothorax, a tumour, or it may be related to dextrocardia, the heart being on the right side primarily instead of the left side. There's an example of dextrocardia with situs inversus. Have a look at the gas bubble on the right side, which is why the orientation is telling you this is the right side. So therefore there must be something wrong with the patient, the person. The heart is now on the right side where it should be on the left side. The stomach is on the right side where it should be on the left side. Now let's review what an AP film chest x-ray should encompass. Remember, always use a systematic approach. Write patient, identified. Date, time, correct. The technical quality, which we've just reviewed. Always scan the film from the outside in. Thorax, chest, pleura, lungs, mediastinum, heart, diaphragm, and organs that should be situated below. Remember to always evaluate the chest x-rays with the patient's history, their physical assessment findings, what they're like clinically. If possible, which may not be possible, look at serial chest x-rays to give you an idea of where the changes may have occurred. And then review the technical quality: projection, orientation, penetration, rotation, inspiration, and then you can look at the chest x-ray. Always observe your anomalies in the format of, is it too white? Is it too black? Is it too big? Is it too small? Look, is it in the wrong place? You may not know what the consequences are. That's the job for the radiologist, not the radiographer, not the nurse, not even some of the physicians. We can all look at the chest x-ray basically to identify certain situations, conditions, which is why the x-ray may have been taken, but really the radiologist will be the one that makes the interpretation and will document as such to give us information. We always make sure that the lungs have got equal transradiancy, which means they should essentially be the same blackness on both sides. We should make sure that the vascular markings go from the hilar all the way out to the peripheries. The vascular markings are the white lines or the blood vessels. If they don't go all the way out to the outer areas, thorax, something could be wrong. We make sure that we have hilar, and the hilar are where the lung markings begin. And this also includes things like nerves, lymphatics, arteries, veins. Typically, the left hilar is more elevated than the right hilar because of the positioning of the aorta and the left pulmonary artery. When we review the normal heart, we remember that it's sitting on the diaphragm, the apex is more pronounced, or the image is more on the left, which is normal. An adult cardiothoracic ratio is less than 0.5, and an infant or pediatric cardiothoracic ratio is less than 0.65. When we look at the normal diaphragms, we remember that they're dome-shaped, and their images are really sharp and clear lines. Because remember, we've got an air tissue interface. The lungs are sitting on the diaphragm, which has got the liver under it on the right side. So therefore, the sharp, crisp, clear line should be clear. Then we have on the left side, the heart is sitting on the diaphragm, and it sits under the bowel or stomach, and it may not be as clear because, again, remember, the stomach is tissue, the diaphragm is tissue, and the heart is tissue white. However, if there is a gas bubble under the diaphragm on the left side, the left hemidiaphragm, then it will be even clearer. The right hemidiaphragm is typically higher than the left hemidiaphragm because the liver is pushing it up. And on the left side, the heart is pushing it down. Then we have normal costo-cardiac and phrenic angles. And the costo-phrenic angles are to the outer, the sharp point to the outer on the right and left side, and the costo-cardiac angles are close to the heart. And they are typically, not always, sharp and clear lines because of the normal air tissue interface. Costo-phrenic is now air, lungs, interface with liver. And on the left side, air interface with other organs, typically the stomach, the bowel, the spleen. When it comes to the costo-cardiac angles here, this is air, lungs, and heart. Normal air tissue interface. Then you've got a normal trachea. A normal trachea is typically grey because, again, there's air in the trachea. I don't think you're typically going to see cartilages, which are tissue, but you may. But there is a sharp, clear midline. The trachea is typically midline, and then you get the bifurcation into the right and left main bronchus. This is the carina. And this typically is referred to as having an air bronchogram image because the trachea has got air in it, and as a consequence of that, you will see it as a bronchogram or an air bronchogram image. Then look at the thorax. Always compare the right to the left side. The rib structure should basically be the same. It has white, symmetrical, smooth rib contours of equal density. There shouldn't be any spots in it. Just like there shouldn't be any spots in your spine or vertebrae, because this could indicate that there are lesions there that could be metastatic. Look at the intercostal spaces, because they can be an indication of whether things are problematic, like in a pneumothorax, for example, or chronic lung disease. Always compare the right to the left side and make sure that they're symmetrical with the right and left at the same level with equal width. Then look at the soft tissues. And the soft tissues are the outer areas, and they're typically grey or off-white and of equal density. If you see blackness in there, that could indicate subcutaneous emphysema. If you see increased whiteness there, it could be a hematoma or a collection of fluid or an abscess, which you would have already identified on clinical assessment, on physical assessment. Alright, that comes to the end of part 1 of chest X-ray interpretation. So therefore, if you enjoyed this or you got anything out of it, move on to part 2 and any other of the Dr. Manny Learn Shops that are available on YouTube. Thanks. See you next time.